Let's tease it apart. In my opinion, the complexity of the disease is a gift to science, because that's how you beat it. You beat the disease by tearing it apart into its small components. It's a lot easier to climb a mountain one step at a time, right? So why not segregate it out and just look at those with the beta amyloid, those with tau, those with inflammation, those with et cetera, et cetera, et cetera. You can break it out into many. This is just one version of it. So what we've done over the last couple of years, we've been thinking this was there for many years. What we've started formalizing is saying that these are what we're calling endo phenotypes, subgroups. If I write subgroups, it doesn't sound as catchy, so I can't get published or funded, so come on, that's a joke. We use the term endo phenotypes because what that means is basically it's a biologically based way of identifying a subgroup of patients. The reason these have been selected is because they're biological systems. These are things that, right here, inflammation, that's an immune response. That's your immune response. It gets upregulated when you have a cold. Why? To fight the cold. You cut your arm, your hand swells, that's inflammation. Very simplistically. So what you have are these systems that get dysfunctional. So what we think you should be able to do is targeted clinical trials. Why not treat the biology of the disease of the patient? This is akin to enrolling someone into a diabetes trial by actually testing their glucose or their HbA1c, instead of them coming in saying, oh, by the way, I'm diabetic. Guess what? It's happening right now. First ever trial in the history of humankind that's a true prevention trial of Alzheimer's disease has now started. The A4 trial, that is by Dr. Risa Sperling. How's this trial happening and why is it absolutely so ingenious? They're doing those brain scans that you saw earlier on people without the disease, right? Not people with the disease, people who have brain scan positive plaques in their head and they're cognitively normal, which is 20% of everyone walking around above the age 65. Now, amazing trial, but it's also the most expensive study we've ever done, but because it costs about $5 grand a pop to scan about 4,000 people. And it's about a 3-year trial. So it's the best trial we've ever done. Risa is my hero. I want to be her when I grow up. If I grow up. However, why can't we do this other ways? So there was a really big splash, I guess it was 2 years ago, maybe 3. Suzanne Kraft, now at Wake Forest, published this work that showed that intranasal insulin improved memory in those with Alzheimer's disease. Made huge media stuff. That's now into a full phase 2, potentially phase 3 trial called the SNF trial, which is ongoing right now. What I've told her, and I'm hoping she'll give me the blood samples, is why don't we look at specifically those who have metabolic dysfunction and see whether or not it works for that subgroup of patients. But here's the one where I've spent most of my time and I'm most passionate or, I don't know, perseverative. Inflammation. Inflammation is related to Alzheimer's disease, Parkinson's disease, multiple sclerosis, traumatic brain injury, depression, basically everything, cancer. We've had 3 clinical trials to use anti-inflammatory agents to treat Alzheimer's disease. Every one of them has failed. Every one of them. Why did they fail? Well, here's why. So what we've done is created a way of taking a blood test and determining whether or not someone has dysfunction in their inflammatory system. Not one protein, because that didn't work for the blood test for Alzheimer's disease. What we took was a way of profiling inflammation as a biological system and said someone has dysfunction. They're either split into 3 groups, low, middle, and high. What that means is someone who's low in inflammation are basically immune suppressed at some level. Those who are in the middle group, which is about 70% of people are just somewhere in the middle. Inflammation isn't really high, it's not really low. But then you have a small group, about 15%, where inflammation is through the roof. It's elevated. What happens if you take someone who is immunosuppressed and you put them on an anti-inflammatory or an immunosuppressant drug? Bad things happen. So, this is a real clinical trial. This is a failed clinical trial. This came from this right here, the Alzheimer's Disease Cooperative Studies. They did one Alzheimer's, one pre-Alzheimer's. We took the blood samples from this trial. Those blood samples taken before they enrolled to the study, so it was pre-randomization. Took the blood from the patients and created a profile, split them up by low inflammation, medium inflammation, and high inflammation. So, let's look at this group. You take people who have low inflammation and you don't treat them. You leave them alone. They stay normal over 12 months. They don't really change. The bar graphs are in each group because of one person. They don't change. What happens if you take someone who has no inflammation and you put them on an anti-inflammatory drug? Normal decline in an Alzheimer's patient is somewhere around here. They decline worse. So in other words, you give them an anti-inflammatory drug and you made them worse. In the middle group, they're in the middle group. There's no difference between these two groups. They're just somewhere in the middle. Now, the high group. You take people who have elevated inflammation. Their inflammation is through the roof, system-wide, okay? This isn't one marker. They have true system dysfunction. And you do not treat them. They decline worse over 12 months than if you would not have treated them at all. If you'd have left them alone, they would have actually been just fine. If you treat them, however, that's the comparison. They get better. When you go from this group to this group, what happens is basically 64% of the patients in this group actually got better over 12 months. Now, it's a subgroup. It's 15% of the patients. This graph is a graph of a doomed clinical trial. Because adverse responders, 15%, 15%, non-responders, 70%. Every clinical trial that's designed is oversensitive to this because we don't want to treat people and make them worse. So if you have adverse responders, trials are stopped. That's those people. This is the other 70. So you've got 85% of the patients were somewhere in here and only 15% got better. So what you have is true identification of a subgroup of patients with Alzheimer's disease who you can treat with specific drugs. So if I back up and do this, and you go from brain disease, Alzheimer's disease, inflammation, treat. And you have a clinical trial that says that it works. Presented that in Copenhagen this year at the Alzheimer's International Conference. What we're working on now is, this is inflammation, as I said earlier. It's not unique to Alzheimer's disease. Beta amyloid might be. This may be very specific to Alzheimer's disease. This is not specific to Alzheimer's disease. As a matter of fact, beta amyloid's in other diseases, but this is prominent in some other diseases, particularly FTD. This and this and this and this are prominent in Parkinson's, in frontotemporal dementia, in multiple sclerosis, in et cetera, et cetera, et cetera. So what you have now is potential of subdividing patients into therapeutic groups. So one of the things that we were asked to do, and this is something that actually just happened, so it's not even, because I gave you this slide this like a week or so ago. Subsequent to that, we now have data where we've taken and looked at this pro-inflammatory, this group, this biological group, to determine, does it exist in animal models? Because the animal models are kind of how we start finding new drugs. We play around in those models that we think are the biology of the disease, and we move forward. Actually, it's incredibly prevalent. As a matter of fact, when you go to these three groups, in the animal models without Alzheimer's disease, 30% are here, 70% are here. So your control mice, and 0 here, by the way, none. When you're in the Alzheimer's triple transgenic mutation Alzheimer's disease mice, where we know they have the disease because we've manipulated them genetically to have the disease, 60% here, 40% here, 0% here. So even in our animal models, which we think are, by the way, most people think that your animal models, all the animals are the same. There are no such thing as subgroups. There are very clear subgroups, even in the animal models. Well, okay, so what about, sorry I'm doing this because I couldn't update this because they already had it. It's his fault. Everything's your fault today, you know that, right? My plane's late, it's your fault. Interestingly enough, that same group, that's 15% here, that inflammatory group, it's 20% here, it's about 60% here. It is 50% here, 40% here, and it's about 70% of Down syndrome patients. So this group is it's a biological system is all it is, but it's dysfunctional across neurodegenerative diseases. So what we're trying to do now, there's a clinical trial pending where if funded, it will do this. We will enroll patients by the blood test. They get a clinical diagnosis of Alzheimer's disease, they come in, they get a blood test. If their blood test shows this profile, they go into the trial. They get an anti-inflammatory drug, determines whether or not it makes them better. Does it slow progression, does it make them better? It would be the first true targeted trial for Alzheimer's disease that has happened other than beta amyloid. So we're pretty excited about that. What it has, though, is larger implications in that it may be a way of addressing neurological issues, dementia, right? We tease apart dementias because as scientists, we like classifying things. As clinicians, we want to know what the disease is. So we put a name to it, we understand the biology of it, and we treat it. Unfortunately, in neurological diseases, that has helped us zero. We don't have effective treatments for Alzheimer's, Parkinson's, frontotemporal multiple sclerosis. We don't actually have effective treatments for any of them. But what's interesting is that when you look at the diseases together, there's a lot of commonalities. A lot of commonalities. You can find beta amyloid in Parkinson's disease. You can find tau in Parkinson's, frontotemporal, other diseases. There was this genetic mutation that was going to be the test for frontotemporal dementia. Unfortunately, it was found in Alzheimer's, Parkinson's, and multiple sclerosis. These diseases are alike, just like they are different. Okay? The blood test, when I showed you, 100% accurate, right? At discriminating amongst the diseases? It is, but there's a caveat. The profile of every disease is different with overlap. So you have inflammation that's in there, but the profile's still a little different. The profile for one disease. So there's overlap and there are differences between the diseases, but that could open up novel opportunities for treating a whole lot of things. Actually, in the airport, on the way home today, I'm meeting with a Japanese company that's testing a new drug about using this to predict treatment response in their new drug for Alzheimer's. And last week, I met with a company that wants to do it in multiple sclerosis. What is this called? Personalized medicine. This is person-centered therapy. You're treating the patient based on the biology of that patient. That's why cardiology has done so well. Does anyone know what the death rates of heart disease have had in the last 20, 30, 40, 50 years? That. What are the death rates due to cancer done in the last 20 years? That. What are the death rates due to AIDS done in the last 15 years? Gone down. Why? Because we've understood the complexity of the diseases. If you go into the science of oncology, there are people in oncology who don't even want to use the word cancer anymore. They want it to go away. Because telling someone they have cancer tells them what? Nothing. Tells you, you may be dying, but that's all it tells you. What kind of cancer? Is it breast cancer? Okay, what kind of breast cancer? Cancer is treating, now they're looking at treatments that are specific to the molecular makeup of the cancer cell. We have treatment cure rates in cancer that are amazing. Heart disease, they're amazing. Why? Because we've deconstructed the disease, the diseases. There's no such thing as heart disease. Really? There's no such thing as, I love that, dyslipidemia. Okay, that means my lipids are somehow messed up. Okay, how useful is that? Go see your cardiologist. He's going to treat you very specifically. So that's where some of the newer work, and why I say, I get frustrated oftentimes when I see the news, because what I see is another failed trial in Alzheimer's disease, another blah, blah, blah. And it's disheartening to the community, it's disheartening to society. And I feel it is my responsibility as a scientist to say, stop it. We're working very hard. And the science has moved on. When you see about those clinical trials, those failed clinical trials, when they go back and look at them, 30% of the patients who were in those beta amyloid drug trials didn't even have beta amyloid in the brain. Well, that's called a doomed trial. It's like treating people for diabetes who don't have diabetes, right? So, but that's not a failure. Because of that, we now have the A4 trial. We have the first ever prevention trial in human history for trying to stop this disease from ever happening in the first place. The field, and this is why oftentimes when you see, I said it, a hope for the future. The field is actually, I believe, on the verge of some amazing things. We've got potential for not only using a blood test to diagnose the disease, but we have potential for diagnosis of blood tests who will predict future onset of the disease. Well, why do I want to know I might have Alzheimer's in the future? Because now we can try to prevent it. Treating prevalent Alzheimer's disease is like treating stage 3 and 4 cancer. How successful are we when we treat stage 4 cancer? It's abysmal. It's too late. We need to treat earlier and earlier and earlier if we want to get at the disease. When I showed you that picture of the brain, sorry, I'm just back. I'm going all over the place in this thing. Hope you don't mind. But this is a very important point. The brain doesn't regrow. That's a very fundamental phenomenon you need to understand. If I'm treating this and want it to look like that, it's impossible. It's impossible. There's nothing I can do to make that brain look like that brain ever, because I can't make the brain regenerate. Okay? Not like this, I can't. So what we want to do is treat it when it still looks like this. When there's still brain to protect. When there's still neurons and there's still a memory center left in the brain. We want to protect it. We want to keep it there and keep it robust. So what we have